Okay, think about this. If you wake up, say, with a really bad sore throat, you pretty much know the drill, right? You go see your regular doctor, maybe get a strep test, get some antibiotics. It's straightforward. But when it comes to getting help for a mental health issue, that clear path just seems to dissolve. Trying to figure out where to even start can feel, well, kind of mystifying.
Yeah, that confusion is definitely the first big wall people hit. And right behind it, shame, stigma. People often hide psychiatric problems because they're afraid,
Yeah.
afraid of being judged, maybe losing their job. It's become more okay to talk about recovering from surgery, but mental health struggles, often kept in the shadows.
And it's wild because the illness itself can sometimes actively push against getting help.
Yeah, it's such a critical point. We really need to understand that right away.
Sure.
Take psychotic disorders. Sometimes a person literally can't recognize they need help. The term for that is anosognosia. It's fascinating and frankly terrifying.
Yeah.
The illness itself blocks the awareness of being ill. You can't really start treatment if you don't think there's anything wrong.
Wow, yeah. That's a really tough cycle to break.
It is. And think about something common like major depression. The apathy, the hopelessness, that sheer lack of energy, it just makes everything harder. Even finding a therapist number or making that call can feel overwhelming, like climbing Mount Everest. But today, we're going to try and map out that mountain range. Our mission here is to lay out the whole structure of psychiatric mental health care. We'll focus on the continuum of care and this key idea, the least restrictive environment.
Okay, good. So to understand the system now, maybe we should look back a bit. American psychiatric care used to be all about those huge asylums. How did we get from that to the community-based approach we have, or aim for, today?
Right. Historically, back in the 1950s, we had something like 500,000 people living in these massive state hospitals, often really isolated. The big shift began partly due to policy changes in the 1960s. Medicare and Medicaid coming into play was huge. Crucially, Medicaid would pay for short hospital stays in general hospitals, but usually not for long-term care in state psychiatric facilities.
Yeah.
So suddenly states had this massive financial reason to move people out to the community.
And didn't the Supreme Court kind of cement that shift later on? I'm thinking of the Olmstead case in '99.
Yes, exactly. Olmstead, that was a landmark decision. It basically said that keeping people institutionalized when they could live in the community was unjustified isolation, a violation of the Americans with Disabilities Act. It established a legal right, essentially, to live in the community setting.
Which sounds great, from a rights perspective,
Yeah.
but if you close down hospitals without really beefing up the community support first, didn't that kind of just move the problem to, like, the streets, jails, ERs?
That's the fundamental tension, yes. It's been the challenge ever since. Olmstead gave the legal right, but building the actual stuff needed in the community, housing, jobs, coordinated clinics, that takes serious, sustained funding and effort. Many communities have really struggled to provide that robust infrastructure. The system is still, in many ways, playing catch-up.
So when someone does enter this varied system, what guides their path? You mentioned the continuum of care. It's not just a straight line, is it?
No, not at all. It's fluid. Think of it like levels. If someone gets discharged from, say, an inpatient unit, the highest level of care, they need strong support right away, intensive follow-up. If those supports aren't there, they can easily decompensate. That means their mental health deteriorates and boom, they're right back in the hospital. The goal is always to help people move towards and stay in the least restrictive setting possible for them.
Okay, so let's define the ends of that spectrum. What's the core difference between outpatient and inpatient care?
So outpatient is the least restrictive end. You're living independently, mostly. Supervision is intermittent, maybe a therapy appointment once a week, something like that. Inpatient is the most restrictive. We're talking 24-hour supervision inside a very controlled, safe, structured environment, a therapeutic milieu.
Got it. Let's start with outpatient then, the least restrictive side. It seems like primary care providers, PCPs, often end up being the first stop for many.
They often are, yeah.
Yeah.
And it makes sense, right? Going to your family doctor feels less loaded, less stigmatizing than walking into a big psychiatric clinic. Plus, a lot of mental health issues, especially things like anxiety or depression, can show up first as physical symptoms, headaches, stomach problems, fatigue. So seeing your PCP seems logical.
But the big downside is pretty clear. Time and specific training. You can't really do a deep psychiatric assessment in a 15-minute checkup.
Exactly. It's just not enough time. That's why we have specialized providers, psychiatrists, psychiatric nurse practitioners, psychologists, social workers, counselors. These folks have the specific training needed. They can offer things like psychotherapy, detailed medication management. Though who can prescribe what does vary by state. especially for APRNs and PAs.
And to fight that problem you mentioned earlier, care being split between physical and mental health, there's this model called the patient-centered medical home, the PCMH. What's the goal there?
Yeah, the PCMH model tries to fix that fragmentation. Historically, insurance often paid better for physical care than mental health care, creating these separate silos. A PCMH aims to bring it all together. Primary care, mental health, maybe social services too. The key ideas are that care should be patient-centered, comprehensive, well-coordinated, easily accessible, like offering longer hours or email contact, and it should all be based on, evidence and best practices.
Okay. And for people who maybe don't have good insurance or much money, there are the community mental health centers or CMHCs. They sound like a crucial safety net.
Oh, absolutely vital. They are the backbone for so many people. CMHCs usually offer services for free or on a sliding scale based on income, and they do a lot. Emergency services, medication clinics, therapy groups, even intensive case management, helping people with housing, benefits, everything. They're really essential for community stability.
We also have psychiatric home care. Who is that specifically for?
Right, that's for people who are literally homebound. They can't leave their home easily because of physical or mental health conditions. For Medicare to cover it, there are specific rules. The person has to be certified as homebound, have a psychiatric diagnosis, need the skills of a psychiatric RN, and it all has to be under a clinician's ordered plan of care.
Then there's something called Assertive Community Treatment ACT teams. That sounds really hands-on.
It is. It's probably the most intensive form of community support. ACT is for people who are often described as hard to engage. These are folks usually with severe, persistent symptoms, maybe chronic psychosis, who find it really hard to stick to regular appointments. ACT teams include various professionals. They're on call 24/7, and they go to the person. They work with them in their homes and their communities, trying to catch problems early and prevent that revolving door back to the hospital.
Okay, so if someone needs more structure than, say, weekly therapy, but doesn't need to be in the hospital 24/7, there are intermediate steps, like IOPs and PHPs.
Exactly. Intensive Outpatient Programs, IOPs, and Partial Hospitalization Programs, PHPs, they bridge that gap. The main difference is intensity and time. PHP is more intense, like a structured program running maybe 6 hours a day, Monday to Friday. You're safe to go home at night, but you get a lot of therapeutic structure during the day. An IOP is a step down from that. Fewer hours per day, maybe 3 hours per session, and usually 3 to 5 days a week. PHP provides that daytime structure, while IOP allows someone maybe to get back to work or school part-time while still getting significant support.
And one more outpatient thing before we move on to telepsychiatry. It's exploded, hasn't it? Especially recently.
Yeah, absolutely. Massive growth. The benefits are huge, reaching people in remote areas, getting rid of travel barriers, and it definitely lowers the stigma hurdle for some folks. The really key thing to remember, though, for providers is licensing. You have to be licensed in the state where the patient is physically located during the session, even if they're just on their couch at home.
Right. Okay, shifting gears slightly. Let's talk about the nurse's role, particularly in these outpatient settings. The sources talk about prevention using a public health model.
Yeah, it's a useful way to think about interventions. Primary prevention is about reducing new cases, the incidence, like teaching coping skills to teenagers who might be vulnerable to stress. Secondary prevention aims to reduce the number of active cases at any given time, the prevalence. This involves things like screening, early detection, and getting people into treatment quickly.
And the third level, tertiary prevention.
Tertiary prevention is about rehabilitation. It's about trying to reduce the long-term impact of an illness, preventing disability or even death.
Yeah.
So, for example, helping someone with severe depression manage their illness well enough so they don't lose their job, that's tertiary prevention, preventing that loss of function.
So in these community settings, the psych nurse needs to be pretty independent, right? And really focused on this idea of recovery.
Definitely. Recovery is the guiding star. It's about helping people live meaningful, self-directed lives, even if they have an ongoing illness. It's not always about a cure in the traditional sense. The nurse needs strong assessment skills, problem-solving abilities, and really good knowledge of all the local resources.
Yeah.
They're often leading the charge in making sure care is truly patient-centered, driven by what the patient wants and needs.
Okay, let's pivot now to the other end of the spectrum, inpatient care, the most restrictive setting. When does it reach the point that someone has to be hospitalized?
Hospitalization is really reserved for acute situations where there's immediate danger. The criteria are usually pretty strict. The person is actively suicidal, homicidal, or so severely disabled by their symptoms, maybe acute psychosis, unable to care for basic needs that they can't be safe anywhere else. This kind of acute care happens in a few places. Crisis stabilization units, which are for very short stays, maybe 1 to 3 days, just to get things under control quickly. Then you have psychiatric units in general hospitals, dedicated private psychiatric hospitals, and state psychiatric hospitals.
And the state hospitals, those are sort of the descendants of the old asylum system. They handle the most severe cases now, and forensic cases.
Largely, yes. State hospitals tend to care for individuals with the most severe, persistent illnesses, often people who need longer-term care than private facilities provide. And yes, they also provide a lot of forensic care, treating people who are involved with the legal system, like those found not guilty by reason of insanity or NGRI, or needing evaluation for competency to stand trial.
When someone is admitted, what's the immediate process and what are the big safety worries?
Well, it starts with triage, figuring out how urgent the situation is, and then stabilization. A huge, constant safety concern on inpatient units is elopement. That's when a patient leaves the unit without permission before they're discharged. It's sometimes called AWOL. That's why units are locked. And for patients who are particularly high risk, perhaps aggressive or extremely impulsive, there are often specialized psychiatric intensive care units or PICUs with even higher levels of staffing and security.
This is where things get really complex ethically, isn't it? Because even when someone is hospitalized, maybe even involuntarily, they still have rights, including the right to the least restrictive treatment possible within that setting.
Absolutely fundamental. That principle applies everywhere on the continuum. Hospitalized patients retain their basic civil rights. The right to refuse treatment, including medication, is a big one. The right to private communication, the right to informed consent for any procedure. The whole team, but especially nurses who are there, 247, are constantly balancing respecting those rights with the immediate need to keep the patient and everyone else safe.
And the environment itself is considered part of the treatment, the therapeutic milieu.
Yes, milieu just means surroundings or environment. In psychiatric care, it's this idea that everything is part of the therapy. The physical space, the people, staff, and other patients, the daily structure, the rules, the overall emotional atmosphere. A well-managed, predictable, safe milieu is thought to be essential for helping people feel secure enough to start healing.
Managing crises in that kind of environment must be incredibly demanding for nurses.
It requires very specific skills. Staff get training in de-escalation techniques, trying to manage agitation verbally first. And again, that ethical tightrope. Seclusion, isolating someone in a room, and restraint, physically holding or using mechanical restraints, are only used as an absolute last resort when there's imminent danger. They require constant monitoring and a physician's order very quickly. They're safety tools, but they represent the most extreme end of restriction.
And the physical design of the unit itself has to be built around safety, too.
Oh, completely. It's crucial for preventing self-harm or harm to others. Things like having windows made of safety glass unlocked, doors that open outwards so patients can't barricade themselves in, furniture that's bolted down, even things like closet bars that are designed to break away if someone tries to hang something heavy on them. And organizations like the Joint Commission mandate ongoing suicide risk assessments for every single patient.
So the inpatient psychiatric RN, they're really the constant presence managing all of this 24/7.
They absolutely are. Their role is huge. Managing that therapeutic milieu day to day. Providing often complex physical care because people with serious mental illness frequently have co-occurring medical conditions that need close attention. And critically, administering medications and evaluating how they're working or not working. Observing side effects. That input is vital for guiding treatment decisions, especially around medication changes. They are truly central to stabilizing the patient.
Okay, just to round things out, let's quickly touch on some of the specialized treatment settings.
Sure. So we have specialized units or hospitals for children and adolescents, and for older adults, geriatric psychiatry, because their needs are different, considering development or aging issues like dementia. The Veterans Administration System, the VA, sees huge numbers of veterans, particularly needing treatment for PTSD. The rates are quite high for those who served in Iraq and Afghanistan, for example.
And we should mention forensic psychiatry again, for people in jails or prisons, and also specific treatment for substance use.
Right. Forensic settings deal with incarcerated individuals. Estimates suggest about 20% of people in jail have a serious mental illness, or people referred by the courts, and then dedicated alcohol and drug use disorder treatment. That can range from inpatient medical detoxification, managing potentially dangerous withdrawal, to outpatient counseling and relapse prevention programs. And finally, maybe just a quick mention of self-help options. Things like support groups.
Yeah, that's important too. Groups run by NAMI, the National Alliance on Mental Illness, or 12-step programs like AA. They aren't formal treatment, but they can be incredibly helpful additions. They really tie into that theme of empowerment, recovery, and peer support.
Absolutely.
Okay, so wrapping this all up, it seems like our deep dive shows that getting into the mental health care system can be really tough, with barriers like stigma and that concept of anosognosia. But once you're in, the system itself is designed as this fluid continuum, from least to most restrictive, all guided by that core principle, the least restrictive environment appropriate for the person's needs.
Exactly. And maybe a final thought to leave you with revolves around that inherent tension, especially at the inpatient end. Think about the constant ethical challenge nurses and doctors face. Balancing a patient's fundamental right to make their own choices, their autonomy, even the choice to refuse treatment against the responsibility to protect that same person from potentially lethal harm when they are acutely unwell. How do you navigate that day in, day out? It's probably the central, most difficult question in acute psychiatric care.
It really is a profound balancing act. Well, thank you so much for exploring this with us today. We hope this map of the psychiatric mental health care system has been helpful for you.